So very good morning to everyone. First of all, let me apologize that I am in the Dubai airport, so that I cannot answer your questions. And you may go ahead through my email, and then I can answer to you. And I always thankful to Dr. UP Singh, because even though he is working as a private setup, he formed a prime academic society to teach others. That is a wonderful thing what he is doing. And this is my email ID. You can write it down, and I will be covering ATRIAL SEPTAL defect in the echo in decision making. So this is a grim fairy tale. And here one doctor was so depressed and financially he was in trouble and he was about to suicide. Suddenly an angel appeared. He was not happy because the angel appeared, but he was a bit happy. The angel showed a full box of jewels and gold, and suddenly the angel disappeared. Then he was so much happy because he can take up all the treasures, and he was so happy. And finally, this has happened. I say that do not look at your treasures, but look on to the services you are giving to your patients. The congenital heart disease is divided into a cyanotic heart disease and cyanotic heart disease. Remember, the 8 to 10 structural heart disease out of 1,000 live birth is congenital heart disease. And of course, the left to right shunt is a cyanotic, and right to left shunt is a cyanotic heart disease. As a general rule, just remember that the oxygen saturation between 90 and 95 with a heart murmur, if you are observing, that is definitely a left right shunt. Along with that, if you are seeing a tachycardia and the respiratory movements are so fast, that is called tachypnea. That is definitely child is because of the left right shunt, child is in heart failure. So the left to right shunt is a cyanotic, and right to left is cyanotic heart disease. And one slide on cyanotic heart disease. So, you all learned 5 T's even during our graduation. That is nothing but the tetralogy of Fallot and transposition of the great artery, truncus arteriosus, and tricuspid atresia, and total anomalous pulmonary venous return. And I will be covering only the atrial septal defect under the left to right shunt. I know that many delegates are doing the course frequently, and it is their duty to checklist abdominal situs, cardiac position, systemic veins, IVC, SVC, pulmonary veins, atria and IAS, IAB valves, ventricles and interventricular septum, great artery relationship, pulmonary artery and branches, and PDA. Then you won't miss any structural heart disease in your echo. So I'll be dealing only the intra-atrial septum within another 20 minutes. The basic cardiac segments, when you look at this, the intra-atrial septum separating the right atrium and the left atrium. So the intra-atrial septum we will study a little bit. And this is an example of the fetal cardiac development. I want to show in a small video clip. The caudal end will gives SVC and ASD. The cranial end will be the aortic root. And within 3 weeks, that is 21 days to 24 days, this cardiac tube will rotate and forms the caudal end, the SVC and IVC, and the upper portion will be truncus. And this truncus will be again further divided into atrial, the aorta, and the pulmonary artery. Look at this, the sagittal section of the 2-chamber heart with the 2 AV valve, and this 2-chamber will be divided and further to 4-chamber. Look at this, how the intra-atrial septum forms. There is a septum primum, grows from the upper superior end and go down and forms the ostium primum, and through which the right to the left shunt taking place at the fetal life. You know that is going to close, but God provided another hole that is called ostium secundum, and then the ostium primum will close. And another septum will form from the superior portion, and that is the septum secundum. And before touching, again another hole will form in the center, communicating with the ostium secundum, and that portion is called foramen ovale. The atrial septal defect embryology, as you know, the in general failure of septation or the atrial septum. 1 in 1,000 live birth is atrial septal defect, and the females are more prone to get this ASD structural defect, and 5 to 10% of congenital heart defects is atrial septal defect. What all you need to know in ASD is ideal views for evaluation, anatomical types of ASD. That is very important. You have to describe what type of ASD, because if it is a second-time ASD, it is purely indicated for the device closure, unless other is very large the second-time. SVC ASD also you have to mention very clearly, because we want to describe the pulmonary venous drainage, and the ASD rims are important, how to assess their severity and intervention, when to do it. The 2D echocardiogram views, I always say that the subcostal view, you have to learn properly. If the subcostal view is, you are taking up very nicely, very clearly, even in adult, except the fatty patients, we can see the defect very clearly. So the subcostal view, if you are seeing very nicely the defect, you don't need it a transencephalic echocardiography. Subcostal biatrial view I have to see, bicaval view, apical four-chamber view. I say that TE can be avoided if subcostal view is accessible in both children and adults. But TE is essential during the procedure in the cath room if it is moderate to large ASD, because you should not make any trouble of the device placement properly to place the device. This is the positions in pediatric echocardiography. Simply I am showing even sitting, right lateral position, on hand, make it as a pacifier, and very nicely you can see. In children, only the right lateral parasol longitudinal view I take it only for the SVCASD demonstration. Otherwise, always in children, it's the supine position is best. The sedation, if I give one word, Finnegan is the best. In all my 20 years of experience, the Finnegan is superb, and it can be the child can be sedated. Only thing, if the child is slept while they're coming to your OPD, then may be a trouble. But even within 20 minutes, if you can give 1 dose of chloral hydrate like an add-on drug, then child will be sedated very nicely. But remember, both Finnegan and chloral hydrate can make irritability and severe cry can occur, that you just simply explain to the parents, and they won't make any trouble with you. But now the midazolam is available, so the nasal spray 0.2 milligram per kg body weight. That means, in simply, if you can remember, 2 meteor dose in each nostril, below 1 year, below 4 years 2 to 3, below 10 years 4 to 6, etc. So the atrial septal defects are 5 types are available. That is ostium secundum in the center, SVC type, IVC type, and the unroofed coronary sinus. The coronary sinus, but the anterior roof is deficient. And these are the specimens which I'm showing an examples of the secundum ASD. This is a good case for the device closure. This left atrial disc and right atrial disc, and is very nicely we can close it. But various rims of ASD, you have to explain the rim which is near to the mitral rim, or a tricuspid valve rim. Of a tricuspid valve, we call it as a mitral rim still. And the rim which is anterior, that is the aorta plays anteriorly, that just below the aorta, that is the anterior rim, and just superior, superior rim. The anterosuperior rim also very small or zero, then also a trouble for a device closure, because it can prolapse. So you should be very careful. But with the expert hand, maybe with the balloon, it can occur. So the IVC rim also important to describe, that I will show you. This is a normal heart which showing purely biatrial view. This is the left atrium, this is the right atrium. In the biatrial view, this is not SVC, and this is the bicaval view. Very nicely we are demonstrating, and so that the SVC you can demonstrate. If the RSVC is absent, then you can see very nicely. Then you have to look at the coronary sinus. If it is dilated, you know that there is a left coronary sinus. So there is a left SVC. That is important to explain, because surgeon need it, because the surgeon anesthetist also need it, because they want to cannulate both SVCs bilateral. If it is SVC, right SVC or left SVC, they have to cannulate. Otherwise, while closing the ASD, the oozing from the coronary sinus from the left SVC, that make a trouble for them to suture the pericardial patch. So especially when they are doing the minimally invasive surgery. In the minimally invasive surgery, remember that you can cannulate only the RSVC, not LSVC. So you have to explain, if it is LSVC is there, they will go straight away the sternotomy. This is the example of a SVC ASD. Here you can see the echo dropout very nicely, you can see, and the color flow is between this defect fills, then it is a SVC ASD. And the tip, if it is thick and like a chopping like appearance, then also definite SVC ASD. Maybe you sometimes you may see the blue color, nothing to worry, because the flow from the left atrium going up and coming down, so it is going away from the probe. The flow towards the probe, it is red. So both red and blue you can see. But if you are seeing from the right side, it is blue, then it is a bidirectional shunt. It's called Eisenmenger syndrome. So this is typical. This is the right pulmonary artery, and this is the SVC, and you can see very nicely demonstrate SVC ASD. And here, this is an example of the lower type of second-time ASD. There, the IV serum is very short. Such case also, you have to be very careful, and you have to explain to the interventional cardiologist that the IV serum is short, so that may prolapse, so that they have to use the balloon technique. And if you have a still doubt on SVC ASD, right parasternal long axis view, and the IA should prominent, and then upper portion, you can clearly demonstrate the left to right shunt very nicely in the SVC. You have to try, then you will appreciate this modified right parasternal plaques view, modified for the intraatrial septum. Many times you saw the second ASD flow even in the parasternal long axis view when you move little anterior or posterior. So same view, you modify it and you can see the left to right color flow. And if you have a still doubt, you may take two syringes and 10 cc syringes, one syringe with the saline and one is empty, and mix it thoroughly, the air, mix it properly, and then the wonderful contrast study you can see. And you can see the air bubbles are coming through the hole, and it is nothing but a SVC ASD. And that is very important thing to measure. The apical four-chamber view measurement may be erratic. Sometimes even without a septal defect, the color flow gain is high. The flow may be supersede over the septum. You may think that it is a defect. So I won't prefer for the size taking in the four-chamber view, unless otherwise very small children. And this is an example of the coronary sinus dilator. There is an equal sign. I made it as equal sign. This is dilated coronary sinus. And such cases, you should be careful when you are putting a device, because the device may partially obstruct the coronary sinus. It can it can collapse. So you have to be very careful while using the devices in such a lower type and very near the dilated coronary sinus. And because the surgeons are very competent to do the device, the minimally invasive surgery, so why you are unnecessarily taking a risk for a large ASDs for a device closure? That is my question. That is my view. It can maybe different. This is the earlier days we do the scapular area, that is posterior lateral thoracotomy. This is anterior lateral thoracotomy. Now we are putting a very 3 centimeter submammary incision. This is a subaxillary incision, vertical. That is not good actually, because against the crease, but still some people are having a good scar. And if it is a thick keloid formation, then it will be a trouble. And these are the minimally invasive scars. So surgeons are well competent And if it is a large and if it is risky, if it is consider your child as your own child. Aneurysmal ASD, sometimes we see nothing to worry. This very thin membrane will be opposed each other between the left atrial and right atrial disc. So still it can be closed. And this is an example of the perforator ASD. You can see three jets. If you are going your sheath through the upper one, lower part maybe a residual shunt may occur. If you are going through lower, then upper portion can occur. If you are going through the center, both can be covered. You are only thing you take little 1 or 2 mm extra above your calculation. This is the same one I showed as anatomical specimen. It's a cribriform type ASD with 2 holes. You can see this can make a residual shunt. So you should be very careful. This is the fossa ovalis. This is the septum secundum, and this is the septum primum, and this is the ostium secundum, that is the small hole. If this hole by echo, if it is less than 5, just wait and watch it. There is no atrial RA or RV dilatation. Just leave it alone. But if it is RA RV dilatation, it's an indication for ASD closure. In general, above 6 mm is an indication for device closure. This is an example of the the upper or high type secondum ASD. Still, it can be closed. Whereas this one, the IVC rim is 0. So that is not able to close by your device. You have to send for the surgeons. So device we are putting in the left atrium disc and right atrial disc and oppose each other in the secondum type. And if you have 2 holes, still it is possible with 2 devices. And after post-procedural echo in ASD device with the TE probe in 90-degree bicaval view showed ASD in situ. How you know that in proper? Because this is my explanation diagrammatically. I said there's a dove shape. If the dove is there, you don't have to worry anything. You just remove the cable. That's all. Well fitted. If you are not seeing this dove, then you have to reposition it. And even with the 2D echo, you can see that 3D view of your device with your pin, etc. So when not to do intervention, PFO, if it is less than 5 mm, rims are inadequate, and the anterosuperior rim and IVC especially, ASD size is large and disproportionate to the weight of the baby. Suppose 10 kg child need a 16 mm, I won't prefer to put a device. You can go ahead for the surgery. So there is a rule. If it is a very large ASD for a smaller weight babies, better go ahead for the surgery. ASD size is small, but RA is bigger. Then something is wrong. You have to find out the anomalous pulmonary venous drainage, partial type. So that need a CT angio. See, with the CT angio, very clearly you can demonstrate, and especially SVC ASD. I used to send all the SVC ASD for CT angio because we had a lesson that even we demonstrate all for pulmonary vein 2R draining into LA, 2R in the RA, but still there is an anomalous pulmonary vein 4 mm draining the innominate and SVC junction. If I am not doing the CT angio, I may miss it. So you have to identify the anomalous pulmonary vein also to tell to the surgeon that here draw a picture and show where are the pulmonary vein draining. So accordingly, they will put a flap and do the Warden procedure properly. So the role of cardiologist is a very important thing in the diagnosis of the ASD. And this is an example of the severe pulmonary artery hypertension. And always I say that while you are doing suspected cases with the device closure, put the sheath into the pulmonary artery and measure the pulmonary artery pressure. If it is less than 50% of the systemic, go ahead for device closure. If it is high, then you should be careful, because in Eisenmenger, especially with oxygen saturation is low, and there definitely is an Eisenmenger state, or near systemic also, leave it alone. Your ASD is a blessing for them. At least their life is longevity will be improved. and Eisenmenger is very dangerous to close. So thank you once again for this online CMA program to teach this ASD section. Thank you once again.